All right, hello everyone. Uh, well, thanks for everyone who could actually join today. Before we start, I hope everyone is safe, everyone's taking care of each other. Yeah, before we start today's lecture, let's actually talk about the exam and everything. So, okay, before I start the exam, and guys, please, I would love to hear your opinions on everything because I'm trying to be as flexible as I can. And for me to do that, I need to hear what you guys are thinking. So I'm just quickly going to turn off my video for the bandwidth. Okay, so what I'm proposing right now for the new syllabus, so basically the course structure with the exams and everything, is that I give the first exam, and the first exam will basically be covering actually weeks 1 to 6, so chapters 1 to 6, basically. Those would be the ones that I basically would like to cover at chapters basically 1 to 6, which will be 30%. So it's just one extra chapter that I've added because what I'm planning to do is that I not don't have a second exam, but rather having two assignments. One are basically clinical cases on autoimmunity and hypersensitivity reactions, which is 15%. You get this basically, and you will basically I will most probably put the deadline by the end of April. And then you get the second assignment, which is an essay on cancer immunotherapy. Again, 15% deadline will be also the same. I would say hopefully release it basically after Thursday, and you would have both assignments, and you would have basically about a month and a half or so. And then you would have the final exam in where I won't make it cumulative. I will only make it covering basically weeks 10 to basically 15. These assignments, basically, I will not test you them on. Sorry, I'm just letting people in. So this would be the final then exam would be like weeks 10 to 15. So these are for the people that just entered basically the lecture. So I'm proposing a new syllabus in where the first exam would be covering weeks 1 to 6. And what is weeks 1 to 6 would be basically actually no, 1 to 6 would be literally chapters 1 to 5. So it's chapter 1 to 5 technically. So tolerance and autoimmune diseases are not there. This is actually I forgot. I've actually added it to the hypersensitivity reaction. So no, basically week 1 to 6 would be then chapters 1 to 5. So I think the only thing extra that you would have is now the B cells, because we said up to a point of T cells, then now it would be up to the point of B cells. So you would have to just actually just learn about the B cell basically development, and that would be the first exam. The assignment number 1 and 2 basically would be all due on the April 30th. You would have about a month and a half to finish this off. The first assignment would be clinical cases on autoimmunity and hypersensitivity reactions. And the assignment number 2 would be an essay on cancer immunotherapy. Of course, I'll be giving you a lot much more instructions than just purely this. Then the final exam would be covering weeks 10 to 15, which basically this would mean, so if we go now to here, we'd be going from chapters 9 to chapter 15. So that would be basically what I would basically be involving in. No cumulative, just purely weeks 10 to 15. And that would be your final exam, which would be worth 40%. Can you guys share any thoughts? Do you guys think this is fair or not? Let me know.
I think it's fair.
Okay, perfect. That's good to hear. Perfect. Thank you,
Okay.
Medium.
Is exam one MCQ only?
So yeah, that's what we're gonna be talking about in a bit. So I'm gonna remove the essay part, but I want to see what you guys think would be the best thing to replace it with. Would be MCQs, or would it be basically something else? We'll shortly talk about that. So this would be the new basic, because one thing I don't want you guys right now, because I really understand you guys, I really do, with like this everything that's happening, it's a bit annoying. Well, annoying is let's say the least of the words, but I would say I don't want what I don't want you guys is, for example, to have you guys have to exam number one, let's say somewhere in March 30th or April 1st, and then 2, 3 weeks later, I'm giving you another exam, and then a couple of weeks later, you're having a final exam. I don't think that's really the best plan. Can the final be 35 instead of 40%? Try to make exam one MCQ only. We'll talk about the MCQ basically part one in a bit. For Jute, for basically 35 instead of 40, that I cannot really change because basically I can there's a certain amount of percentages that I need to play around with, and basically the final exam has to be 40% per se right now. That's the only thing I cannot really change. But I'm quite sure that you guys will do extremely well in assignments one and two. So that's like an easy 30% to actually get. Like, I'm quite sure a lot of you guys, if you look through the lectures, you basically have some internet basically access as well there, you'll definitely ace them quite well. They're not, they're not tricky. The assignment one is clinical cases, which are quite, let's say, straightforward. They're just to show you how people in the clinic really think when it comes to autoimmunity and hypersensitivity reactions. The SM cancer immunotherapy is literally I'm giving you a disease which is lymphoma, B-cell lymphoma, and I'm telling you what cancer immunotherapy would you do to treat this. Bring me up with anything you want, as long as everything is has a pattern, has a rationale, everything you're saying is actually quite good. I'm quite sure you'll get a 15%, basically like a full 15%. So they're made. I'm actually making these more for you guys to do mostly a bit of outside reading more than anything else. Like, of course, to listen to my lectures, but also to just read what's outside there more than anything. Okay, well, if this is fine, I'm just waiting just purely on the course coordinator to just give me the final okay with this. But hopefully I'll get it and I'll basically confirm this to you guys ASAP. So, just quickly see the chat. Sorry, one second, guys. At what stage of the trial should the therapy be? That's a great question, Miriam. I will leave that basically to your, uh, let's say, imagination. You can choose whatever, like, it could be a therapy that you just came up with. If you have a good rationale and you have a great, what do you call it? Let's say, if it makes sense, I'll definitely score it quite highly. Honestly, it could be a therapy that's basically been approved, or it could be a therapy that you're just coming up with. So for exam number I agree. Approved ones are boring. I agree. Approved ones are boring. So definitely, I would say go something a bit more imagination, like imagine something up. Exam number one. So first of all, I'm gonna postpone it. I'm not gonna make it on the 27th, like I was basically saying, on 26th that I said, because I know that you guys have basically some exams. Basically, I think you have ecology and some other exam as well during that week. So I'm gonna postpone it. So I'm thinking of doing it March 31st or 1st of April. What days would you guys, let's say, prefer? Okay, we have Lean saying April 1. Anyone wants to pitch in? Because to me, these are the two dates that I'm planning to give it. Okay, April 1st, April 1st. Sadly I cannot postpone it till April 13. It's too long, it's too far. Honestly, the people in the department are pushing me to do it even now to that point because they want a grade. Let's put it this way. They want a grade to be put it already there before I don't know if there's an escalation or something happening. So this is already pushing it. Yes, Jude, it will be online. Thank you for that. Basically, Beirut exams are have to be online. We're not allowed to bring you in. Ruha, I cannot postpone it to April 7 or anytime second week of April because again, already 31st and 1st of April, I'm pushing it, technically. Like the whole faculty want me to do it like ASAP. So I'm already pushing it to put it here. Okay, so I guess from what I can see, 1st of April. Okay, well, I'll basically make some arrangements and I'll send you the confirmation by today. So now is the essay part. So guys, the essay part for me, where when I added this was purely because personally I don't like MCQ questions. Even when I was in university, when I was in uni, we had some exams that were half MCQ and half essays, and then exams were just purely essays. I enjoyed more essays because I actually would be able to show the instructor what I've learned. An MCQ, it could be simply because some MCQ questions are really testing more. Did you read the question well? Some of them are just tricky in the English language. To me, I don't really enjoy those MCQ questions. To me, it's more like you're not really testing 100% someone's knowledge. So that's why I added it. But now I understand, of course, I did receive people's emails and everything that under the current circumstances, I understand that it's a lot. I know that it can be a lot, and I don't want to pressure you guys. I actually want this course to be, let's say, enjoyable. So, what would you guys have it? Like, would you have it purely MCQs, or would you have it, let's say, short answer questions, or what would you like for it? So, Jude, like the subjective parts would be bonus. The subjective parts, do you mean the essay, or I don't still understand? Oh, there can be short answer questions. So making them all basically extra po bonus points. That's, I don't think, something that the faculty would be really happy with. Like, I kind of have to make them graded in some sort of way. Okay, medium, I suggest we could do like a report on extra reading or breakthrough or paper. That's actually a good suggestion, like basically a report on the extra reading or breakthroughs. Actually, that's a really good thing, medium. I think that's why I've left the assignments because both assignments need a bit of extra reading. Believe it or not, they both need it. So that's why, okay, I'll definitely take that in consideration. MCQs, MCQs, thinking. Okay, so there's a lot of things that are mentioned. Yep, that's true. There's a lot of things for sure. Uh, just thinking, well. Okay, so I guess a lot of you use on MCQs. It's that's the thing. It's a bit hard to, of course, to think um what can come up we can come up with. Okay, you know what? What I'm gonna do actually, and tell me what you guys think. So I'm gonna make the first exam all MCQs. We're gonna make it MCQs for people. But the basically the assignment one and assignment two, those I'm gonna make them requiring outside reading, meaning that you guys need to basically dive into outside, basically outside the course lectures. Meaning the essay has to be something basically not that I've basically 100% that I've mentioned. It has to be something that you've read, for example, in the essay, uh, something that you've come up with. And same thing goes with basically, well, the clinical cases, it's fine. They're just questions. There will be some questions that I need you that will require you to read outside. Does that make it seem fair to everyone? So you actually have a part that's MCQs, and the other parts, the assignments, are a bit more, let's say, the assignments are more outside reading. Okay, perfect. That's good to hear. Okay, so Heather, basically just a quick recap. So I'm proposing this new, let's say, grading syllabus, and where the exam would be covering weeks 1 to 6, which means chapters 1 to 5. So I've just added an extra, basically lecture, which is basically the B cells, and that would be 30% all MCQs. Assignment one and two would be clinical cases on autoimmunity and hypersensitivity reactions. And assignment two would be an essay on cancer immunotherapy. As I was saying, I would be giving out, let's say, and that basically telling you guys you have a disease like lymphoma, so B-cell malignancy, and I need you to come up with a cancer immunotherapy for that. So that would be the 15%. Assignment one and two, I would need you guys to do outside reading there. So I need you guys to come up with something outside. Of course, the clinical cases, there will be questions that are not in the lecture, so that will require you to actually read outside to, answer it properly. And assignment two, the essay, also will require you basically to read outside. The final exam would be covering weeks to 10 to 15. This is basically chapters 9 to basically 15, and that would be around 40%. So I think I will also most probably do it all MCQ or something, but I'll definitely will update you guys there soon. Hopefully, if it's still we're still under this war, it's gonna be definitely MCQs. If it's not, if we're basically hopefully like it ends sooner, well, we'll come up with something together. No worries at all. Okay, guys. So no backtracking for exam one. Yes, medium. That's correct. So basically, as I don't know if many people have told you right now, but the Beirut exams will be all of them will be online. They will all basically all be no, you're not going to be able to backtrack. Basically, there will be, of course, on Blackboard, there could be closed browsers. You guys need to log in into WebEx or Zoom, and we're going to be proctoring through there. So you need to have your webcams open so we can see what you guys are doing, and basically, and make sure your phones are not there, and no backtracking. Exactly. Meaning that once you finish with the question, you cannot go back. So please make sure that when you're done with the MCQ question, you actually are 100% with it. So will the MCQ questions be the ones we did? Yes, and there will be like that. So I've given you examples. I've put some examples also. Other than we did it, I've also added some examples in on Blackboard. Some other extra examples, I think.
Doctor,
Yes.
is it not possible to have the exam on campus?
Yeah, that's the thing. Like I would prefer it that way, but that's up to the faculty. The faculty have made it. They made it a very clear rule. Exams in Beirut are online, and basically exams in Biblos are in person. That's something that I have to follow with the faculty's decision.
But we're coming for the labs. Tomorrow we're coming just to do lab work and like for the lab sessions. Why can't we come for like an hour, do an exam,
I agree with
and
you.
that's it?
I completely agree with you. But again, these are things that I cannot.
Because we can face a lot of difficulties, especially with connection or هيك.
Ahlam Zatari, we have another exam on campus. Okay, okay, okay. I
We
will
have a micro lab midterm tomorrow, in person.
in person as well. Like I got the proper like guidelines about it has to be online from Beirut. Like I know, for example, I give BIO420, and I basically in Biblos it's in person, but I know the person that's giving it in Beirut, she has to make it online as well. Let me speak to basically Dr. Sama Saiman. She will let me know if I can do it in both, because I think it would be better to do it both. So, people, if the people want to do it in person, they come and do it in person. And the people that want to do it basically online, they'll do it online. Then I guess everyone will be happy. But if I have to choose, basically, I think it's going to be online. But I'll definitely make sure about that. But what I've been told, it has to be online. Am I posting the recordings? Yes, I'm posting the recordings. I posted actually, sorry about the take me some time, but I posted the last ones, the chapter 7. And I even posted the pre-recording of this lecture today even. Okay, guys. I will definitely once I get everything, let's say, sorted out. So the exam is going to be all MCQs that I can definitely 100% tell you. The exam will be on April 1st. I'll send you an email about this proposed syllabus. I'm just waiting. I've sent this already to the course coordinators, and I just need their okay, and then I'll send you this 100%. And then I'll actually also give you assignment one and two and the deadline and everything. Okay, so now on to today's lecture. All right, tumor immunity. So no bias at all here, but this is basically, I have to say, one of my most favorite lectures that I will be giving today, or basically this semester, because I am the most comfortable with tumor immunology. I've been working in tumor immunology now for the past almost 6, 7 years. No, even more, even like something like around 8 years even, in tumor immunology. So if you guys have any questions or any, let's say, curiosity, please feel free to let me know. So let's start off with cancer. So as we know, cancer is one of those diseases that we never want to hear a doctor utter to us. It's, as we know, a very horrific disease. And sadly, and I'm going to be very honest, the incidence of cancers are increasing every day. To the point that back in the day, we used to come up with this example, look to the person to your left and look to the person to your right. One of you guys will actually have cancer. Now it's not even that. Now it's one in two will be diagnosed in cancer in our lifetimes. And it's to the point where I think it's gonna come to the point if we don't able to find a way to stop it, it's gonna be becoming almost every person. And the thing about cancer, as we know what technically cancer is, at the simplest, let's say, definition, is purely a normal cell that has turned cancerous, or has turned, let's say, has transformed in a sense that is proliferating like crazy, nonstop. That's what we mean. It's turned cancerous. It's turned into a point that it's literally um, proliferating uncontrollably. And the issue with cancer per se is metastasis. Is that once we have a cancer that's, let's say, now kind of, originated from, let's say, imagine our liver, the issue is not that it basically invades our liver, is that it starts to actually detach, metastasize to other parts, specifically your heart, your brain, your bones, these areas where you can cause extreme pain, but also can tap into very sensitive functions, like in the brain or in the heart, and that can basically be lethal. And the good thing about it is that we've started to actually really understand and uncover the main, let's say, functions of our immune system when it comes to cancer. Let me put this way. In our body, around 1,000 cancer cells are developing every day. Why they do not develop into a big tumor is purely because of our immune system. Our immune system has the ability to sniff out and to kill cancer cells on a daily basis. So, other than basically our immune system able to protect us from basically bacteria or viruses or parasites or fungi, you name it, they also can protect us from cancer. And they do this on a daily basis. So, when it comes to basically, you know, because the immune system and cancer, after knowing that our immune system has a huge role in protecting us against cancer, there has been always this kind of fantasy of using our own immune system as a drug, as basically these soldiers to go and kill basically our cancer. Because imagine this, we are already vaccinated against basically almost every single type of microorganism that can actually can kill us. What about if we can actually immunize against cancer? Imagine if you can actually take your T cells, teach them to go and kill your cancer cells specifically while leaving your normal cells healthy, intact. That would be the holy grail if we can make a T cell response against your cancer. Because, first of all, you would have tiny little soldiers inside your body doing all the work, it would be safe. And in the case of relapse, and where that's majority of the cases of cancer, and where people suddenly have no more cancer, basically they are cured from cancer, then they basically have uh, they have a relapse and where their cancer starts to spontaneously grow again. Imagine if you have a T cell response, a memory response, that can actually kill it before it can actually give us symptoms. Again, it would be the Holy Grail. And that's when basically, and this thing actually has been fantasized, not recently, this has been fantasized almost a century ago. Almost a century ago, we really wanted to actually boost our immune system. And we used to do that with actually viruses. I'll talk about that on Thursday, actually. But it's not a new concept. It's a very old concept. And now, if you look at the current cancer immunotherapies or the current, sorry, cancer treatments in the clinic, the majority of them are cancer immunotherapies. Let's say the most novel ones. And I used to think that in Lebanon we didn't have this, but thankfully I was proven wrong. Actually, at AUB, I met a lot of doctors that are doing CAR T cells. They're doing different types of checkpoint inhibitor therapies. These are the modern types of cancer immunotherapies that are in the clinic. So that kind of gave me a bit of basically faith and everything. So I think this is definitely going to be developed furthermore here in Lebanon, thankfully. But if you look at the cancer therapy, the cancer treatments, you have your traditional therapies, which are basically surgery, radiation, chemotherapy, targeted therapy, but it's mostly always combined nowadays with cancer immunotherapy. Now it's literally that is the biggest blockbusters that are really helping us in the clinic right now. But what led us to actually develop these new cancer immunotherapies? Really, it was the discovery of tumor immunity. So, we, of course, as majority of our findings, they all originate from mice because we use mice a lot to do a lot of basically studies. And what we saw is that in a mouse, you can actually induce cancer by giving carcinogens or radiation to a mouse and it will develop a tumor. But what we can do is we can actually take out that tumor and then transplant it to another mouse. So we started to see that we're able to transplant tumors from one mouse to the other. And I do this literally, sadly, on almost a daily basis. I do this quite a lot. Back in Finland for my research, because I need to study the interaction of cancer with the mouse's immune system. But one thing that we see is that not all the tumors you transplant will actually be accepted. Some of them will be actually rejected. And what you clearly see is especially with tumors expressing foreign MHC molecules. So imagine this. Imagine you have this blue mouse. I take its tumor, and this blue mouse, the tumor has an MHC-A. Let's imagine. We then transplant it to a mouse, to a, let's say, a yellow mouse that has an MHC-B. When we put this basically tumor to this yellow mouse that has MHC-B, it's going to find the MHC-A on the tumor as foreign, and it's going to kill it. That already told us that there is some sort of immune system that we can actually generate against the tumor. It's one of the first actually experiments. And then came up different types of experiments. This is a very cool one. So what they did here, they got basically this yellow mouse. They injected it here with this basically red tumor. And they gave it this irradiated tumor cells. So irradiated tumor cells means that these are tumor cells that have been killed with irradiation. They do not proliferate. These, think about them as a vaccine. These are actually called whole cell vaccines. I'll be talking about this on the last chapter about vaccines. So basically what happens is this mouse now generates a T cell response against these red tumor cells. When we inject now viable red tumor cells, so these are able to proliferate, this mouse does not have any tumor formation because we've actually induced a T cell response. We have taught this mouse's T cells to kill any tumor, any red tumor. But if I take this mouse again and I inject it with a different tumor, so now your blue one, we get actually the formation of it. So this already told us that there is some sort of T cell response that is specific that we're generating and that we can use it actually to protect us. And of course, we did many different types of experiments. So what we saw is that if we took this mouse over here, before injecting them with the blue tumor cells, we removed the T cells from this person, from this basically mouse, No, sorry, again, I did a mistake. So this one here. So if you look at this mouse over here, if we remove the T cells from this mouse, these red cells would be able to grow. So this really demonstrated that T cells were the ones responsible for the protection. And we also see this basically in adoptive transfer. So if I take T cells, let's say, if I take basically now T cells that are against the blue tumor cells and I inject it here, this tumor would be rejected. So we can actually adoptively transfer immunity through T cells. So as long as you have a T cell response against a tumor, it can be protective. Because what we found out, what can actually happen is two things. Is either an antigen presenting cell or a tumor cell per se, a cell by itself, can present an antigen. Because remember, all nucleated cells have an MHC1. They can present antigens. And these antigens, we call them tumor rejection antigens. So these are antigens that reject the tumor. So you put them up on your MHC1, you present it to your T cell, and you can actually activate them. And of course, your activated T cells now start to expand and they start to go and kill any cell that expresses that tumor rejection antigen, which is mostly your tumor cells. So this is what basically happens. So very similar, let's say, to an infected cell, a cell that's infected with a virus. It's that infected cell has viral antigens. Well, this tumor cell has tumor antigens that can be used as a target. And again, this tumor immunity concept is not new. This is going back to the early 20th century, so a century ago. Specifically, this brilliant scientist, Paul Ulrich. Paul Ulrich, we dub him as the father of immunology. He has, let's say, discovered the core concept of immunology. And he was one of the first people that came up and said that he believes that our immune system is able to monitor and eliminate cancer cells. And he was right. He was completely right. Then came up in 1950s, Frank McFarlane and Lewis Thomas proposed this new theory that they've called immune surveillance, and where they started to hypothesize that our immune system actually surveils our whole body for cancer cells. And they came up with basically a hypothesis which they called immunocancer immunoediting, and where the immune system can edit your cancer. And this is a very cool concept. So what this basically consists of, it consists of three sequential phases. The first one is elimination. Name is very self-explanatory. It's where your immune system eliminates your cancer. But there's always sometimes in where your tumor, your immune cells are not able to kill your cancer cells 100%. They're able to kill, let's say, 90%. There's that 10% of tumor cells that are there, but they're kept in equilibrium, meaning that your immune system does not allow them to proliferate, but basically, and it is not killing them. So the immune cell, basically, the tumor cells are literally, let's say, constant. So hence in equilibrium. This can cause actually some sort of pressure, some genetic pressure that can make these tumor cells start to change. And some of these tumor cells start to learn through genetic, basically, mutations, how to escape your immune system. And they enter the final phase, which is escaping. So this is how your immune system can edit these cells. So I'll go through this very, into more details. So as we said, you have basically this red tumor cells over here. You have this elimination phase. You have all these different types of immune cells coming in to kill. They try to kill as much as they can, but there's always going to be some of them. So basically, you have this more pinkish kind of cell, which is, a bit hidden. It's not proliferating, and it's not dying. It's there. It's in this nice equilibrium phase. You have this growth, but very, very, very slow. It's almost at this equilibrium phase. But what happens here is that because there's a pressure of these immune cells, and these cells are realizing that there's a pressure, their genomes start to become more unstable, and they start to produce many different mutations. And by random chance, it's pure random, it's a lottery, that one of these, specifically this one over here with this basically kind of round-ish, kind of oval-ish nucleus, or this one over here that I'm pointing to, will develop a mutation that's going to be able for it to actually proliferate like crazy, but also hide from your immune system. So your immune system are not going to be able to recognize it. And they're going to be into the escape phase. So this is where your immune system is pushing sometimes your tumor cells to actually go into this kind of equilibrium phase and to edit their genes and for them to become much more, let's say, kind of invisible to your immune system. And for tumors, for cancer cells to be successful in growing, they need to do this. If they're not able to evade your immune system, they will never grow. So this is a priority for your cancer cells to do. So, as we said, the elimination phase, what you see is you have a different types of cells coming in. You have natural killer cells. And what natural killer cells do here a lot is they love to kill abnormal cells with reduced MHC expression. So as I said, all nucleated cells have MHC1. However, sometimes when this cell is infected with a virus, what the virus does, it loves to reduce MHC expression. It loves to remove it down, to bring it down, because it doesn't want it to present its antigens. So it becomes actually invisible to your immune system. But cancer also does that. The cancer tries to reduce MHC expression to make sure that in this case over here, they're not being killed. Well, NK cells can actually feel that. If the natural killer cell goes in and starts to, look, kind of filter your cells, and if it sees a cell without an MHC, that already is a warning for it, and it actually might kill it. So you have CD8 cells, CD8 cytotoxic T cells that are killing through tumor antigens. You have macrophages that are actually killing through phagocytosis or releasing reactive oxygen or nitrogen intermediates. You have dendritic cells, which are also doing phagocytosis and presenting tumor antigens to your adaptive immunity, so your T cells or your B cells. But also, what you have is from your macrophages and dendritic cells, you have the production of other cytokines that can have a big role. You have interferon gamma or type 1 interferons, which all of them basically can induce MHC expression, but interferon gamma has a very anti-cancerous property. It can stop cancers from proliferating. And I'll definitely talk about this a bit more into small details. But this is usually what happens, technically. Usually what happens is you have a cancer cell that usually is dying and it releases these antigens. So there's tumor rejection antigens. A dendritic cell comes up, it picks them up, it processes them, and it goes to basically your lymph node. It presents it to your T cells and it creates a T cell response. These T cells, specifically cytotoxic T cells, which are CD8 positive, they traffic into your tumor. They recognize the tumors expressing this basically tumor rejection antigen, and they kill it. And it's basically this wheel. We call this the cancer immunotherapy wheel. This is what basically happens. And this is just for your own information. If you ever hear these cases, which I'm quite sure you've definitely heard, of people coming into the clinic having cancer, they undergo many rounds of chemotherapy and it's not successful. They're then basically sent home to go under palliative care. And palliative care is basically when you have no more, uh, basically, there's no more other medications to treat you. So now you're just treating any symptoms. You're trying to give this patient a comfortable death, let's put it this way. So what happens is these people that go into palliative care that are supposed to, let's say, die in a couple of months or so, suddenly have a complete tumor disappearance. Their tumor disappears. I've heard this. I've had my uncle's wife going to the same basically thing. She went to the palliative care and suddenly she basically her body was able to remove her cancer. It's because of this. Because chemotherapy, what it does, it's gonna kill so much your tumor cells that you have a lot of release of these antigens. So you create this immune response. So what happens in lymphomas, driven trend? Nope, lymphomas have basically are they basically the same thing. They're basically you have the killing of your B cells because lymphomas 95% of them are actually originating from B cells. Basically, they're dying through chemotherapy as well, and they're releasing antigens, which they are being picked up by dendritic cells, and again, and actually, believe it or not, cancer immunotherapy for lymphomas are much easier than solid tumors. Solid tumors, they are actually much more they can get much more bigger. And for an immune cell to go inside a solid tumor is actually really hard. When it comes to lymphomas, these kind of, let's say, blood cancers, hematological cancers, we call them liquid cancers. They're more liquidy, so they're much more easier to be accessed by your immune cells. So your actually cancer immunotherapy is much more successful with lymphomas than, for example, solid tumors. So now you come to your equilibrium phase. So again, your equilibrium phase, you're literally putting a pressure. So you're literally imagine this is basically you have your these are your T cells. They're killing all your different types of cancer cells, and of course comes here they're killing all the green ones, then you're killing all basically almost all the blue ones. But now over here there's an incomplete response over here, and they're not growing. They're not basically dying either. They're in this equilibrium phase, but there's a pressure. There's a big pressure from your immune system that's exerting, and these now are gonna start accumulating mutations. And by pure chance, pure chance, one mutation is gonna make it gain, let's say, one function that's gonna help it evade your immune system, and you enter your escape phase. It's literally, so if we have this clonal expansion, one genetic alteration, so now suddenly you have basically this kind of rather than blue cells, you have now this brown one. This brown cell suddenly has an advantage against your immune system, and this can start growing. This could be loss of tumor antigen expression. This could be reduction of MHC. This could be secreting immunosuppressive cytokines, recruitment of Tregs, many things that I'm going to be talking about soon. Anything of these that could basically help it to protect itself. So what's the evidence that this actually exists, that this whole immunoediting exists? Well, we started to see that in mice, when you remove perforin, so perforin is this very nice kind of molecule that's produced by NK cells and cytotoxic T cells to kill target cells. These mice that don't have perforin, other than being susceptible to infection, they increase the number of lymphomas. They have a lot of lymphomas, a lot of B cell malignancies, actually. Mice that actually lack RAC proteins, meaning that they're not able to generate B or T cells, they actually start to develop epithelial tumors much more frequently. Mice deficient in STAT1. STAT1 is a very important um, signaling, basically protein that really helps to do the signaling cascade during immune responses. If that is removed, you actually have a huge susceptibility to tumor formation because you don't have anymore this formation of immune response. So imagine that, like, and you see this a lot actually with mice or generally human beings that are immunocompromised, meaning that their immune system is compromised or they lack it. They do have a huge increase in cancers. So this tells you that your cancers are there to actually kill you, to basically kill your tumor cells. And we see, of course, not just cells that are there able to kill, you see also cytokines. Like as I said, interferon gamma that's being released, they start to actually increase, of course, dendritic cells and macrophages to increase MHC1 presentation. If you go back to MHC1 presentation, interferon gamma helps us a lot with the ADAP. It helps us with basically the immunoproteasomes. It helps us again with the MHC1 presentation. But also interferon gamma can actually induce tumor cells to actually die. It can actually push them into apoptosis and reduce their cell proliferation. So now the clinical evidence for equilibrium, actually this came from a very, very famous case. So what happened here is you had basically a patient that actually needed a kidney transplant. So what they did is they took this basically healthy volunteer, or they thought he was healthy. They took his kidney and they basically transplanted it to the patient. The patient, of course, was receiving basically, of course, this sorry, this immunosuppressive drugs, and these immunosuppressive drugs were, of course, pushing down the immune system of this patient. And suddenly, they started to see that this patient developed melanoma. But weirdly enough, the healthy volunteer that gave his kidney, also developed melanoma. He then later on developed melanoma. They realized that both the melanoma cells were exactly the same. What had happened, then they really found out that the healthy volunteer that gave his kidney had melanoma cells, but they were in this equilibrium phase and where they were not basically survive, basically proliferating or not dying. And melanoma, it loves to metastasize, and specifically to the kidneys. So what happened is that, and by the way, melanoma is skin cancer. So melanoma cells went to the kidney, they stuck to the kidney. So what happened is they took this kidney, they put it in this now patient. This patient basically now is immunocompromised because of the immunosuppressive drugs, and they grew. They were managed to release from this equilibrium phase. So this was basically an example to show you uh, that equilibrium phase does exist. Another thing you see this a lot is with immunosuppressed patients. People that are immunocompromised either by drugs or by basically having infections or by having genetic mutations, they are actually susceptible to cancers. And one thing that you see this a lot is in post-transplant lymphoproliferative disorder. What this means is a condition in where you're infected with Epstein-Barr virus. So this virus, it's the kissing disease, as mononucleosis. It causes mononucleosis. It loves to basically infect B cells, and it stays in B cells. And in normality, it stays there. It stays in equilibrium phase. The B cells are, a bit malignant, but they're not proliferating. They're just there. What happens is that in these patients, when they are immunocompromised, those B cells that are basically now have Epstein-Barr virus, they start to proliferate uncontrollably because they do not have the pressure of of the immune system to basically keep them in check. They're now basically able to just proliferate like crazy, and they become malignancy. So actually, a big portion of lymphomas coming from B cells actually is because of Epstein-Barr virus. It's a nasty virus. I would say 70 to 80% of actually people have Epstein-Barr virus. Actually, it's a very, very common virus to actually have. Let's say the overwhelming majority of people have it. And now comes tumor evasion. Tumor evasion, the mechanisms are plenty. So this could be that the tumor itself has, in generally, a low immunogenicity, that it actually starts to produce zero to very little antigens, or that the antigens that it presents are extremely similar to self antigens. Because you have to remember, a tumor cell, it was before a normal cell. So it's going to have a lot of self antigens. So it's only going to present self antigens. So that can actually then stop. It cannot really produce much of a T cell response because, again, you have tolerance, peripheral tolerance that's going to stop it. Then, of course, basically, then sometimes what happens is that some tumor cells, like some of them will be able to die, but some of them will basically able to kind of reduce the amount of antigens being having. But the more, let's say, interesting parts for me are these two, is the tumor cell has now a increase of genetic mutations, and some of these mutations make it start to actually release a lot of different, let's say, molecules that suppress your immune system. This could be cytokines like TGF beta that all they do is they stop immune responses. I'll talk about them. They start producing a lot of different type of chemokines or cytokines that bring Tregs. And as we know, Tregs, what they do is they love to stop immune responses. They can produce also other enzymes like IDO that actually nutritionally stop T cells from proliferating. And we'll talk about this in a bit. What they can also do is they can release a lot of proteins or extracellular matrix proteins like collagen that create a whole physical barrier outside. So it creates this kind of wall that doesn't allow any cancer immunotherapy to come in. So I'll talk about this just briefly. So one that we see a lot is TGF beta that tumor cells start to excrete, and it's called transforming growth factor beta. Hence the name came out, transforming growth factor. And what it does, it literally stops T cell responses, it stops NK cells, it stops B cells from producing basically antibodies, it stops M1 macrophages. All it does, it's there to stop any inflammatory response. And it pushes Tregs. So really, it helps Tregs, which are basically doing the same. They're stopping basically kind of this immune activation. So it's just basically stopping any immune system to do its job. But what also these TGF beta do, they can also create myeloid-derived suppressor cells. What myeloid-derived suppressor cells, they are literally myeloid-derived, meaning that they are cells from the myeloid lineage, which could be monocytes, macrophages, or neutrophils, that have now developed a suppressor phenotype. They become exactly like Tregs. They start to stop all your T cell responses. They stop your B cell responses and NK cell responses as well. They start working like Tregs. And you frequently see them a lot in melanoma, ovarian cancer, lymphomas, but you also see this also in pancreatic cancer. You see this in colorectal cancer, in kidney cancer, you name it. I basically my research revolves a lot around myeloid-derived suppressor cells, and I'll be talking about the therapy that I created against them because these are extremely annoying cells that are really there to basically stop your immune system from doing anything. And another thing that basically tumor cells actually can do is actually upregulate these kind of checkpoints. We spoke about these checkpoints. These are basically things that will bind to T cells and cause them to go into anarchy. We spoke about CTLA4. This can happen. What happens is the tumor cell can release a lot of cytokines that can cause upregulation of CTLA4 on T cells. But what it can also do, the tumor cell, is upregulate a protein called PDL1. PDL1 binds to PD1 on a T cell, and this drives the T cell to go into apoptosis. And this can actually cause tumor basically evasion. And now the biggest, let's say, drugs in the clinic are antibodies that are blocking both the PD1, PDL1 or PD1 or CTLA4 actually. I'll be talking about this more on Thursday. Another basically form of suppression is IDO. IDO is this indole laminine 2,3 dioxygenase. And this is basically secreted by tumor cells. An example is glioblastoma cells. These are basically cells originating from your nervous system. What they do is they release IDO1. And IDO1, what it does, it literally breaks down tryptophan. It breaks it down to kynurenine. And what kynurenine does, it inhibits T cells from proliferating. T cells need tryptophan. They really need it. Without tryptophan, they do not proliferate. Metabolomically, they are in dire need of it. What glioblastoma cells do, they will put the IDO, which breaks it down, and they produce kynurenine, which has an opposite effect. It stops it, actually, from doing proliferation. And the final one is basically this release of extracellular proteins like collagen. And what literally does is it creates this massive kind of wall that doesn't allow any cancer, immune cell like T cells or macrophages or whatever to come in and actually do any death. It doesn't allow it. So now I'm quickly going to shift into the tumor antigens. What are tumor antigens? What are these things? Well, as we know, a cancer cell is per se originates from a normal cell. It's a normal cell that it transformed, that it actually acquired genetic certain mutations that it now has the ability to proliferate uncontrollably. So technically, a lot of the antigens coming from that cancer, a lot of it's self-antigens, the majority of it. So we need to be careful with what antigen, because one thing what happens that what you don't want is you don't want to get an antigen from your tumor, do a vaccine response, because what's going to happen is the T cells are going to kill the cancer, but they're also going to kill healthy cells because those healthy cells will also have that antigen. And you see this a lot. You see basically, for example, in melanoma, again, this is skin cancer. Some skin cancers actually have a lot of self antigens. And if we actually create a T cell response against those self antigens, we kill the skin cancer cells, but we also, as a bystander, we're killing healthy skin cancer, sorry, skin cells, and which causes vitiligo, which basically is where you're killing off your melanocytes. You're basically removing, wiping out your melanin completely. So there are specific, let's say, tumor rejection antigens that we're trying to focus on. And these could be from these different categories. These could be mutated proteins. As I said, cancer cells are mutated, they have mutations, and they generate basically new proteins, mutated proteins. These mutated proteins are not seen in self or let's say healthy cells. These are perfect. And we call these neoantigens. These are new antigens because they're mutated. They're only found in your tumor cell and they're not found in a healthy cell. That is your holy grail. That's exactly what you want because these antigens are very actually safe to administer. Then you have cancer testis antigens. You have differentiation antigens, overexpressed, abnormally modified proteins, or abnormally RNA processed proteins, and viral oncogenes. I'll definitely go into much more details. So tumor antigens coming from mutated genes, as I said, this is your normal cell that produces, let's say, a finished protein that's working functionally. This protein, of course, is always broken down into small antigens and presented. But of course, because these are self-antigens, usually they do not actually induce a T cell response. However, if this cell now becomes mutated, it becomes more, let's say, cancerous, this now new protein has a point mutation. This point mutation now is going to be cut up. So rather than having these red antigens that were self, now you have this green one that is basically coming from the point mutation. This now is a new antigen, a neo antigen that now is actually inducing a T cell response because your T cell has not seen this before. It's not a self antigen for it doesn't see it as in that sense, and it starts to kill it. You see this a lot with a lot of proteins from RAS or P53. If any of you guys have taken cancer, you know that P53 is a very important protein that helps basically our healthy cells to go into apoptosis once it actually attains a mutation. Usually in cancer, this is mutated a lot. RAS is a very important signaling protein that helps actually cells to go to divide uncontrollably. So sometimes what we have is we have RAS proteins that are have a point mutation that makes it actually overfunction. So we see a lot of new antigens within RAS and P53 because these ones are mostly mutated. This to remove P53 and this to make this much more, let's say, active. Another very interesting antigen source are cancer testis antigens. These are very interesting. So there are these testis antigens. These are MAGE proteins and NYSO. These are mostly found in the male testes. So only males have it in basically in our testes. Women, they have mRNA levels of MAGE and NYSO, but they never become actually proteins because women do not have testes. So that's why they're called cancer testes antigens. They basically are mostly found in the testicles. But what happens is that in cancer, because again, cancer, its genome is unstable. It's expressing and causing a lot of different mutations uncontrollably. And what we see, certain cancers that have nothing to do with testicles, like your skin, your epithelial cancers, sarcoma, basically I think also your lung cancers, they start to express cancer testis antigens, not just in men, but also in women. And these are also very good targets for cancer immunotherapy. MAGE and NYSO, basically peptides, are actually quite abundant in testing. They've been tested quite abundantly, I would say. I basically work as a search, some sort of kind of consultant for a company in Finland that they're testing MAGE and NYSO vaccination. And I would say that these proteins that they're very good antigens, they're, let's say, not super effective in the clinic, per se. But they're a good source of antigens to use. Then you have differentiation antigens. These are antigens which are highly expressed, but they're only expressed in a specific type of tissue. An example of this is for example, in melanoma in skin. In your skin cells, you have tyronase, GP100, MART1, GP75. These are all proteins that are all involved in the production of melanin. So you only see these proteins in skin cells. You do not see them in your liver, you don't see them in your kidney or your brain or your heart cells. You don't. Just purely to skin cells. So what happens when you have, let's say, melanoma, so skin cancer starts to upregulate these quite a lot. So what you can do, and people do this quite a lot, you can actually use them as a source of antigen because now you're creating a T cell response specifically going to your skin. So these are called differentiation antigens. These are antigens which are expressed quite highly, but are quite specific to an organ. Then you have overexpressed antigens, very similar concept to differentiation antigens, but these can be expressed everywhere. They're just overexpressed, but they can be everywhere. Give you an example. You have HER2. HER2 is a receptor that is basically needed for growth. It's a growth hormone receptor. So a lot of cells use it to actually help them to grow. These are found in breast cells, but they can be found all over basically your colon cells. They can be found in your intestine, your stomach, you name it. But what we see specifically in breast cell, they over express HER2. So a normal breast cell has, let's say, four HER2 receptors. They overexpress it, so now they have 10 copies, which is abnormal. Because they're now overexpressed, you can actually use this for a vaccination because now this is overexpressed and you can actually induce the T cells to come here. So when you get a T cell and you teach it to kill HER2, the T cell is not going to kill this a lot because it has very little antigen. So the probability of this recognizing it is quite low compared to this. And this is basically what you're trying to do. Another thing is abnormal post-translational modifications. This could be, for example, in the protein level. So what happens here, you have this mucin, and mucin is basically a protein that's found a lot in breast and also pancreatic cells. What you see is that it's usually heavily glycosylated. What happens in cancer is that this mucin is under glycosylated. It means that it has no glycosylation. What glycosylation does very well, it hides antigens. So these areas that are heavily glycosylated, they're not actually accessible to T cells, or they're not accessible for MHC presentation because they have a lot of sugars. So now that this is underglycolated, you have these areas that are now open, and now you can use them as a target. Another thing that you see also is also abnormal, basically post-translation transcriptional modifications. So this is post-translational. So in the translation, this is more transcription. So what happens here is that, as we know, when we're trying to create mRNA, we have a splicing events, right? We actually splice our introns out and we try to put our exons together. What happens in cancer? Sometimes the introns are not spliced out and they're added to the mRNA. So now you create a completely new different protein with that has introns. That you basically literally expressed your introns technically. And you create literally a new form of antigen. These are also called neoantigens because they're new, they're novel, and this is also another holy grail. And then you have viral oncogenes. These are these are coming from cancers that are basically originating from viruses. An example of this is cervical cancer. 99.9% of cervical cancers are coming from the human papillomavirus. So, what papillomavirus does, it infects your basically cervical cancer, your cervical cells. It expresses this E7 protein. So this E7 protein is a protein from the papillomavirus that inhibits retinoblastoma. Retinoblastoma has a very similar effect to p53. These we call them the guardian angels of our cell. These what they do is that if your cell is infected, if your cell has a mutation that can cause cancer, it causes the cell to die. So what does the E7 do? E7 blocks it, and it also has another basically protein called E6 that blocks p53, and it blocks this whole cell from basically going into apoptosis, and induces basically literally in some sort of way proliferation. And this is what happens in cervical cancer, that a papillomavirus is causing the cervical cells to proliferate uncontrollably. Papilloma is not only restricted to cervical cancer, it's also actually can cause rectal cancer, it can cause basically throat cancers, it can cause penile cancers. It's quite a lot. So what you can do is you can create a vaccine against the E6 and E7 proteins because these are a new source. These are you're not supposed to have these proteins. So you can create a vaccine response against them. And that's what actually has been done. It's called Gardasil. It's a new vaccine well, not new, it's a vaccine against E6 and E7 proteins from papillomaviruses. And thanks to this, people believe that we can actually eradicate cervical cancer. So it's a very, very useful vaccine to the point that I really, really hope that they start actually administering this not only to women but also men, because men can be carriers of papilloma. We get less rectal cancer, penile cancer, but we are actually much more the ones that are infecting women with it as well. So it actually helps to serve both of us to protect us from penile and rectal cancer, but also from spreading cervical cancer technically as well. So these are again a whole table summarizing all the different types of antigens that I've been talking about. So today I was just talking about tumor immunology. My next course is going to be much, much more interesting. It's going to be all about different cancer immunotherapies, and that's going to really help you for the essay. So I'm going to be talking to you how we think, like for example, how when I did my PhD, how I thought to create a novel therapy by using these basically kind of let's say information. So guys, does anyone have any questions, anything that you guys want me to kind of answer or further explain? Well, if everything is nice and clear, guys, I hope you guys have a nice continuation of the day. Please feel free to reach out to me if you have any questions or anything. And yeah, have a great day, and I'll see you guys on Thursday.
Thank you, doctor.
Thank you. Thank you.